providing you this virtual summit. Marian Hoffman-Bowman is one of our wonderful faculty members. She runs our aortic clinic and is absolutely all-star clinical researcher. She and Joe Greenman, I and others were participants in this poster competition. We were very fortunate to get a really number of great posters of wonderful scientific work presented. It's all in Whova, so if you go into the poster section, you'll see all the work. We had the challenge of trying to identify a handful for presentation tonight, and that's what you're going to hear. I especially want to thank a couple of our European colleagues who are presenting their science in the middle of the night. I apologize to you for the timing of this seminar, and you'll have a better chance to enjoy us on Saturday morning, which will be, I guess, in the afternoon for you. I'm delighted now then to turn over the live poster session and discussion to my colleague, Marian Hoffman-Bowman. Marian?
Yeah. Thank you, Kim, for the nice introduction, and welcome everyone for the live poster session and the cocktails. I see that at least Dr. Eagle has a glass of red wine. I hope you grabbed one as well. And we received over 35 abstracts, and as Dr. Eagle mentioned, it was really challenging to pick some for presentations. We tried to respect the spectrum of having clinical care, clinical science, basic science, new imaging science. So if your abstract did not get selected for a featured abstract, please don't take it personally. We had really outstanding science submitted. With this, I would like to welcome everybody to ask questions during the sessions. You can put them in the Q&A box or in the chat box, and so we have some time to discuss each abstract. And I would like to kind of start with the first, having the presentation from Dr. De Mulder.
Hello everyone, my name is Anthony De Mulder, and today I will be talking to you about mitral annular disjunction in Marfan syndrome. In patients with Marfan syndrome, the most common cardiovascular manifestations include aortic root dilatation, dissection, and mitral valve prolapse. Arrhythmia and sudden cardiac death are less known manifestations, but have received increasing attention as additional causes of morbidity and mortality in Marfan syndrome, as demonstrated by these numbers. In recent years, mitral annular disjunction has received a growing interest as a potential substrate of ventricular arrhythmia and sudden cardiac death in patients with and without mitral valve prolapse. As you can see here, mitral annular disjunction can be detected by echocardiography by carefully inspecting the mitral valve annulus. As the ventricle contracts, I'm sure you can appreciate the left ventricular myocardial free wall separating from the mitral annulus and sliding underneath it in a curling motion. Prevalence of MET in Marfan syndrome and the relationship with arrhythmia are currently unknown. Therefore, we performed a retrospective single-center study including adults and children with Marfan syndrome who were followed up between 2004 and 2019. Both MET presence and distance were assessed. Outcomes included arrhythmia, aortic events, and mitral valve surgery. To define MET severity, we performed a ROC curve analysis. We classified patients as MET absent or MET present, and then we looked at patients with a cutoff value below or equal to 10 millimeters versus patients above 10 millimeters. Looking at ventricular arrhythmia, we observed both ventricular ectopy and non-sustained VT occurring more frequently in patients with mitral annular disjunction, and especially in patients with mitral annular disjunction above 10 millimeters. Looking at outcome, we saw no differences in aortic events except for patients with MET above 10 millimeters more frequently having aortic events. Both mitral valve surgery and arrhythmic event, VT and sudden cardiac death, were exclusively found in patients with mitral annular disjunction. Furthermore, all of these patients had mitral annular disjunction above 10 millimeters. To conclude, MET was found in 34% of our patients. In patients with MET, 1/3 had a MET distance above 10 millimeter. Presence and extent of mitral annular disjunction is associated with ventricular arrhythmia and mitral valve surgery in patients with Marfan syndrome. Thank you for your attention.
Thank you very much for this presentation. And I would like to invite any questions for this presentation. And while we are waiting for questions, maybe I start with the first one. I noticed that patients with MET also often had mitral valve prolapse, which is obviously well known with Marfan disease. What happens to patients who have MET only, who don't have mitral valve prolapse? Are they also at increased risk for non-sustained VT or mitral valve surgery?
Hi, thank you for this question. Indeed, in current literature, there is data on patients with mitral annular disjunction, but without mitral valve prolapse. And in this literature, this is the paper of Tegart et al. They do show that these patients without mitral valve prolapse, but with mitral annular disjunction, are at increased risk of ventricular arrhythmia. So they even show a paradoxical association between the presence of mitral valve prolapse, being that patients with mitral annular disjunction and with mitral valve prolapse have slightly less risk of arrhythmia compared to patients without mitral valve prolapse.
Thank you very much. Yeah,
this is similar to our data as well.
Dr. Braverman asked a similar question. Do you have any correlates to MRI and specifically to late gadolinium enhancement in those patients with MET and mitral valve prolapse?
That's a very interesting question. This is something we are currently looking into. We don't have data on late gadolinium enhancement yet, but we have adapted our MRI protocol. So we are looking into it right now. And there is data in current literature suggesting that there is increased chance of finding late gadolinium enhancement in the papillary muscles in patients with mitral annular disjunction. So of course we are very interested to see if this is also the case in our patients with Marfan syndrome. But currently we don't have data on it, but we're looking into it.
Thank you. Dr. Yin is asking if this MET can be also seen in non-Marfan patients who have mitral valve disease, or does it have to be a fibrillin mutation?
No, it can definitely be found in non-Marfan patients as well. So it has a strong association with mitral valve prolapse. It can be found in patients with mitral valve prolapse around 25%, but it's seen more often in patients with myxomatous mitral valve disease. So patients with severe myxomatous mitral valve disease, or the Barlow disease, those patients, around almost half of them, have mitral annular disjunction as well. So it's something that is associated with mitral valve disease. It's there in the spectrum, but this is the first time we are looking into it in Marfan syndrome. It's unreported up until now, but it can definitely also be seen in other patients.
Very nice. Maybe one question, how technically challenging is it to identify MET? Is it a normal trained echocardiographer finds this, or do you really have to pay particular attention to identify MET on a clinically indicated ultrasound?
So in the beginning, it takes a bit of a training. So you have to look carefully to see it. But I think as you saw in the video, once you've seen it, you can't really miss it anymore. On echocardiography, it's important to note that the patients with a smaller distance of mitral annular disjunction, those patients can be missed on echocardiography. While the cardiac MRI, there is the detection rate is much higher. It's more sensitive, and therefore it's somewhat of a golden standard right now. But these smaller MET patients can be missed on echocardiography. So it takes a bit of training, but once you see the mitral annular disjunction and if it's clearly there, then you can't miss it on echocardiography.
Thank you very much, and I guess we stay tuned on the long-term follow-up data of your cohort. Thanks a lot, Dr. De Mulder. Thank you.
My pleasure.
Let's move over to the next presentation, which is from Dr. Van Hoof.
In the personalized external aortic root support operation, a custom-made polymer mesh is used to stabilize the aortic root, primarily in patients with Marfan syndrome. Therefore, it is a total tissue-sparing alternative to root replacement. Since 2004, over 350 patients have been operated. The aim of this presentation is to discuss the clinical outcome of the first 200 cases. Marfan syndrome was the most common indication for surgery, and the majority of patients had a normal ventricular and aortic valve function. One of the most interesting applications of this new technique is to perform pairs during mitral valve repair surgery in patients with connective tissue disease. Isolated aortic pairs can typically be performed without the use of cardiopulmonary bypass. In 5 cases, an intraoperative conversion to valve sparing or total root replacement was performed. In 1 case, the procedure was aborted due to coronary injury, and this is the only early death in the entire series. Detailed clinical follow-up was obtained retrospectively for 192 patients, with 1 late death related to pairs. 3 reoperations were needed for failure to achieve complete mesh coverage at the initial operation. Importantly, no ascending aortic dissections occurred in these patients with nearly 600 years of documented follow-up. External stabilization of the aortic root is known to improve valve function. In patients undergoing pairs, there appears to be a lasting improvement in valve function in a subset of patients. In conclusion, pairs is a safe, total tissue sparing alternative to root replacement in select patients. Pairs prevents aortic dissection, and this is consistent with previous studies indicating that the mesh becomes incorporated histologically and that the support stabilizes root dimensions. Aortic valve function is preserved or even improved by this operation.
Thank you very much for this presentation. I'm asking for the audience to submit questions, please. And I would like to start with the first question, Dr. Hoof. What do you think is the long-term advantage of this procedure compared to the traditional valve-sparing root replacement?
So, first of all, thank you for the opportunity to present here. With regards to your question, first of all, it's important to consider that this is a prophylactic procedure, and it is typically performed at lower aortic diameters than a diameter at which total root replacement or valve-sparing root replacement would be used. The average diameter in this cohort was about 46 millimeters. So the initial diameter indication, I just saw a question come in, the initial diameter indication was between 40 and 45 in patients with Marfan syndrome, but over the years, this has moved on to patients up to 65 millimeters. The big advantage is that the aortic root is stabilized without interfering with the native valve, so it's a total tissue sparing alternative.
Is the surgery itself less invasive? Is the recovery period faster than the common surgery done at larger diameters?
So it does remain open heart surgery. It's also a technically quite challenging procedure. As you can see in the figure up top, the mesh has to be pulled underneath the coronary arteries, and there have been a few cases of coronary artery injury. So it's definitely technically challenging. However, most cases can be performed without the use of cardiopulmonary bypass, so also without the use of blood products. And this leads indeed to a hospital stay of a median of 6 days.
Dr. Braverman is asking if you have seen type B dissection in follow-up.
I was just looking at the most recent data today. There is one patient who had a detection of an asymptomatic type B dissection during follow-up. That was one of the concerns often heard in the beginning, is that by stabilizing the ascending aorta, you might get more stress transduced to the aortic arch or the distal aorta. First of all, this would also occur with conventional root replacement or valve-sparing root replacement. Second of all, biomechanical MRI studies have shown that the effect for this operation here is rather limited.
With the experience that you see in your center, what would be the optimal patient for this PERS procedure who would benefit compared to a regular root replacement in a valve-sparing manner?
So I think the truly optimal patient for this procedure is, for example, a patient with Marfan syndrome who has an indication for mitral valve surgery. And for example, this patient has an aortic root of 40 millimeters, and you don't want to give them a valve sparing or a total root replacement at that aortic root diameter of 40 millimeters, but you're opening up their chest anyway. So this would be the ideal indication, and this makes this indication truly prophylactic. Whereas in other cases, when you're just tackling the aortic root, I think the ideal patient would be a young, healthy patient with Marfan syndrome and a normal aortic valve function. There is some evidence that aortic valve function can be slightly improved, but aortic valve function, aortic regurgitation grade should definitely not be more than 2 out of 4.
Thank you very much. Dr. Solomon is asking if you see any further dilatation after pierce or zero, and how often do they survey post pierce?
So actually the implants are provided in 2 sizes, a 95% implant and a 100% implant. And actually these implants, they do not allow dilatation, and in about 45% of cases, a 95% implant is used, for example, with the aim to stabilize aortic valve function. In these patients in whom a 95% diameter implant is used, there is no dilatation postoperatively. Of course, in some anecdotal studies even say that there is a reduction in size, but these patients are operated at about 28 centers worldwide, going from Australia, New Zealand, Czechia, UK and Belgium, for example, not in the US for now. So it's difficult to get consistent imaging, but patients are imaged in our center at 3 months and afterwards at yearly intervals postoperatively.
All right, thank you very much, and thank you for joining this poster presentation at this live session. Thank you.
You're welcome, thank you.
With this, I would like to ask for the next presentation from Dr. Braverman on aortic dissections in pregnancy. Thank you.
Good morning. I'm Alan Braverman. On behalf of Eric Mittauer and the collaborators from the IRAD, I'll present the clinical features and outcomes of pregnancy-related acute aortic dissection. Over a 20-year interval, we surveyed the IRAD and found 29 women with pregnancy-related aortic dissection, representing 1% of women in IRAD. There were 19% of women less than 35 years old had their aortic dissection related to pregnancy. 13 were type A dissections and 16 were type B dissections, and all but 1 woman survived. A quarter of the patients had hypertension and a third were on beta blockers during pregnancy. 56% of women had dissection during pregnancy, with the majority in the 3rd trimester, and 44% were postpartum, averaging about 12.5 days. In women with type A dissection, the ascending aorta was substantially dilated at the time of dissection, whereas in women with type B dissection, the aorta was often not significantly dilated. 69% of women had an aortopathy diagnosis or a family history of aortic disease, with the majority being diagnosed with Marfan syndrome, 2 with Loeys-Dietz, 2 with bicuspid valve, and 3 with a family history of aortic disease. Half of the women were known to have a predisposing aortopathy before their dissection, but importantly, almost half were not discovered to have aortopathy until after the dissection occurred. 3 women with Marfan syndrome had aortic diameters known before dissection, and they ranged between 41 and 47 millimeters. And 2 women with syndromic aortopathy and prior valve-sparing root replacement had a type B dissection related to pregnancy. So aortic dissection related to pregnancy is a rare complication occurring in only 1% of women in the IRAD database. But among women less than 35 years old, 1 in 5 dissections occurred related to pregnancy. Type A dissections related to pregnancy are associated with a dilated ascending aorta, but type B dissections were often not related to significant descending dilatation. And aortopathy conditions are present in most women with pregnancy-related dissection, but many are not recognized until after the dissection occurred. Thank you.
Thank you very much, Dr. Braverman, for this really exciting presentation. While we are waiting for questions, I probably would like to start with the first one, specifically for the patients that presented postpartum with an average of 12 days you mentioned. Did you see any signal if nursing attributed to the postpartum risk of dissection? Can you please unmute yourself?
That's an important question. We did not survey breastfeeding or lactation history as part of the IRAD database. I will say that in another study we've done, we did not recognize that as an association, although that is something that's been raised as a concern.
Thank you. Since I have you here on the spot, may I please ask you for your personal care, how you advise women about nursing?
My own opinion is that, well, first thing I'd say is the vast number of people who have an aortopathy that are monitored throughout pregnancy have a very low risk of an aortic dissection. I think that's a main message, and that we did find that dissection is a rare complication in pregnant women. And it's really among women at high risk. So dilated ascending aorta, maybe post-valve sparing root replacement would be the highest risk patients. So we share a decision. I personally do not recommend against breastfeeding for women. I think it's an important part of motherhood and bonding, and has a lot of benefit to the child. So we talk about it. We talk about the theory. We talk about the mouse model. We talk about what's known from important labs. But it's really a very shared decision. And if one of my patients wants to breastfeed, I don't discourage it.
Yeah. Thank you. There has been another question from Dr. Solomon, if there was any ascertainment with stimulant abuse among those patients in IRAD.
We did not find any association with cocaine use. IRAD didn't ask for methamphetamine as part of one of our questions. Interestingly, only a quarter of the patients had hypertension. And also interesting, amongst the 8 or 9 women whose aortopathy was known, typically Marfan syndrome or Loeys-Dietz, prior to the aortic dissection, 8 out of the 9 women were on beta blockers and still had subsequent aortic dissection. I think the most challenging part one of the most interesting things that we learned from this study was that how frequently the type B dissection occurred in this cohort. It represented almost half of women. And that's something that I think is going to be a challenge to try to recognize what are the triggers for that, and how do you mitigate that risk.
Thank you. I noticed that half of the women had an aortopathy, but it wasn't clinically recognized before they presented with dissection. Are you having any suggestion how we can improve on this part, how to better recognize their risk before they dissect?
Yes, I think 3 of the women had a family history of aortic disease, so I think taking a very careful family history is an important part of caring for people. And otherwise, I think several may have had, may have had subtle features, so that would be possible. And then just recognizing the conditions. These Marfan syndrome, Loeys-Dietz syndrome are not common conditions. Many don't have experience with it, and some don't have features that are going to be recognizable to all clinicians. So I think our work is to educate people about what features to look for, and certainly then to recognize what symptoms could be present with aortic dissection so it can be identified quickly when it does occur.
Thank you. One last question from Dr. Nias. He asked you if you had made any changes in your practice based on these findings from your study.
I think it's very important to do genetic testing for women who suffer or experience an aortic dissection related to pregnancy. In the IRAD, we didn't have follow-up in all women because of referral centers and people moving away and going away, and investigators moving from institutions not having access. My own belief is that I think probably the greatest majority of these rare findings will be related to an underlying genetic marker. So I think that's very important, and family screening is very important. And then it's humbling that aortic dissection does occur when the aorta is moderately dilated in sizes, again, between 4 and 4.5 centimeters, as seen here, in a few patients with Marfan syndrome. So it's hard to, you can't really guarantee a risk-free pregnancy, although we can predict a very low risk for a majority. And I'd like to just take a moment just to pick a shout out to Eric Mittauer, who's a medical student from WashU. I don't know if Eric is on the call tonight or not, but Eric spent the summer with me working on this and did a tremendous job gathering the data and helping collate this for the abstract. So thank you. And thank you for the organizers, and thank you, Dr. Eagle.
Thank you very much, Dr. Braverman. With this, we want to move on to the next presentation from Dr. Ching Johnson. If I can please connect the presentation.
Imaging the thoracic aorta to establish its diameter is essential for gauging the risk of dissection. However, current aortic diameter cut points do not identify all patients at a high risk for dissection, and a more precision-based strategy may be warranted. Accumulation of glycosaminoglycans, or GAGs, is a well-recognized feature of thoracic aortic aneurysms. This is illustrated here by the blue staining material. The purpose of the study was to develop an MRI approach to assess GAG content in thoracic aortic disease. We evaluated 104 ascending aorta samples harvested from individuals with or without TAD. GAGs were quantified histologically based on Alshan blue staining and imaged ex vivo using chemical exchange saturation transfer MRI. This approach capitalizes on the presence of exchangeable protons on the hydroxyl groups of the repeating carbohydrate units of GAGs that effectively generate an endogenous MR contrast signal upon receiving a specific radiofrequency pulse. Control, non-dilated ascending aortas displayed weak Alshan blue staining. In contrast, GAG staining was evident in dilated aortas as either diffuse interlamellar accumulation or large pools. Quantitation revealed a 2.7-fold increase in GAG content in aortopathy samples. Furthermore, GAG content correlated positively with aortic diameter and inversely with elastin content and smooth muscle cell content. To determine if GAGs could be imaged by MR, samples were scanned at 9.4 Tesla. This depicts the T2 weighted scan of a 5 centimeter aorta and the same tissue imaged using CEST MRI. This reveals a territory of increased signal which closely matches a region of GAG accumulation evident by histology. Quantitative data from 25 patients revealed a significant correlation between the CEST signal and histologic data. We next evaluated region-specific CEST signal within a given aorta. As shown, regions of high signal, medium signal, and low signal corresponded to histologic GAG content. Quantification of 18 equidistant regions around the aortic ring displayed a significant correlation between the CEST MR signal and GAG content in registered images. This novel imaging window into the aortic wall raises prospects for aortopathy risk assessment beyond lumen dimensions.
Okay. Thank you very much for this presentation and inviting a question. Maybe I start with the first. What do you think are the barriers to translate this imaging to in vivo imaging at this point?
First, I want to start off by thanking you for having me. We're definitely encouraged by the potential of this of GAG-CEST to be translated over in vivo. Currently, GAG-CEST imaging is used to assess proteoglycan depletion in knee articular cartilage as well as in the lumbar spine. So it's definitely possible. However, there's a few obstacles that need to be overcome. Firstly, we're kind of going the opposite way in that we're we're searching for deposition of proteoglycan in this case. So we need to assess whether or not this imaging modality can assess mild, moderate, and severe disease in vivo. Furthermore, these scans were performed at 9.4 Tesla. When we reduce the MRI field strength, we see a significant reduction in spectral resolution. So proteoglycan is detected at a chemical shift 1 part per million away from that of water. So it becomes significantly more difficult when we go down to 3T and 1.T scanners. Finally, we will need to overcome the obstacle of cardiac motion. So CEST as an imaging modality is extremely sensitive to motion-based artifacts. So these are the general obstacles that we are currently dealing with.
Thank you. And in the samples that you imaged, what was the average size, or what was the smallest diameter where you still were able to detect GAG?
So we were able to detect GAG pretty consistently throughout most diameters. Aortas range in size from 4.5 centimeters to up to 8.
I don't see any other questions right now. Thank you very much, Dr. Jing.
Thank you.
Thank you. With this, we can move on to the next presentation from Dr. Keaton Gagara.
Hello, my name is Ketan Gagda. I'll be summarizing key findings from an ongoing project where we are investigating nanoparticle contrast-enhanced computed tomography for the interrogation of disease severity and early detection of aortic degeneration. Shown here on the left is a cartoon of the nanoparticle CT agent that we used in the study. It consists of approximately 150 nanometer size liposomes. The liposomes encapsulate a very high payload of clinically used small molecule iodine contrast agent. The long blood half-life of nanoparticle CT agents provides 2 modes for the interrogation of aorta. CT imaging performed within a few hours after the administration of contrast agent allows acquisition of CT angiogram for the assessment of aortic enlargement. Delayed CT performed 4 to 5 days after the contrast administration would reveal areas of aortic wall degeneration due to leakage and intramural accumulation of nanoparticle contrast agent, as shown by blue arrows in this picture. This slide shows an example of nanoparticle CT for the detection of preclinical aortic pathology. Gross examination and CT angio indicated a normal ascending aorta. However, delayed CT showed mild signal enhancement in the aortic wall as indicated by the green arrow. Histological analysis demonstrated fragmentation of elastic laminae, and immunofluorescence microscopy confirmed intramural accumulation of nanoparticles, shown in red, and the presence of CD68 positive macrophages, shown in green. Furthermore, the nanoparticle signal did not co-localize with CD68 signal, suggesting passive leakage of nanoparticles due to increased endothelial permeability in regions of aortic damage. We compared the sensitivity of nanoparticle CT against gross examination. As shown in this figure, delayed CT outperformed CT angio and gross examination for the detection of aortic damage. In conclusions, delayed nanoparticle contrast-enhanced CT demonstrated higher sensitivity for the detection of preclinical aortic degeneration and wall inflammation that occurred in the absence of aortic enlargement. Furthermore, this method detected aortic wall injury associated with endothelial dysfunction and enhanced endothelial permeability.
Okay. Thank you very much for this exciting presentation. I would like to ask the question how much the model that you used, high-fat diet with angiotensin, which clearly generates a more inflammatory type of the aneurysm, played a role for the nanoparticle uptake? And are you planning to study this nanoparticle, in a different model of aneurysm that is less inflamed?
Yes, so we do want to study the sensitivity of this method and the nanoparticle in other models of aortic aneurysm and dissection, and that's actually ongoing work to understand the sensitivity in different animal models of aortic dissection.
Okay, thank you. All right, in the interest of time, I think we are moving on to the next presentation from Dr. Tehrani about ARBs and remodeling in Marfan syndrome.
Potential heterogeneity between angiotensin II receptor blockers and their anti-aortic root remodeling properties in Marfan syndrome. Our lab has previously shown that losartan does not inhibit aortic root widening in Marfan syndrome mice through ATR1 and blood pressure dependent pathways, but instead through increased production of nitric oxide, a potent vasodilator and key protective regulator of vascular homeostasis and overall endothelial function. This led us to ask about other ARBs' potential in activating NO and possible heterogeneity that may exist between this class of medications. In order to understand which ARB is best at increasing nitric oxide, mice were treated with different ARBs at equivalent blood pressure lowering doses. The aorta of these mice was then subjected to increasing concentrations of the vasoconstrictor phenylephrine to assess vessel function. The aorta of mice treated with telmisartan showed the greatest inhibition of contractility compared to all other ARBs and was fully rescued following nitric oxide blockade with LNA. This suggests that telmisartan is a potent activator of nitric oxide, further confirmed by telmisartan's loss of effect on inhibition of aortic contractility in mice lacking the eNOS gene responsible for NO production. With telmisartan as the most potent activator of nitric oxide, we treated Marfan mice for 18 weeks with telmisartan at a higher blood pressure lowering dose. Telmisartan treatment was able to fully attenuate aortic root widening in Marfan mice as assessed by echocardiography and resulted in significantly lower blood pressure. It also prevented classical markers of Marfan aortic pathology, preventing increased aortic wall thickness and increased elastic fiber fragmentation in the aorta. Following co-treatment of telmisartan and the NO blocker LNAME, telmisartan was unable to prevent aortic root widening, despite the co-treatment resulting in an equally significant blood pressure lowering. Co-treatment resulted in increased aortic wall thickness and increased elastic fiber fragmentation. We also show that Marfan aortas treated with telmisartan demonstrate lower aortic contractility, which is fully rescued following treatment with LNAME, confirming enhanced NO bioavailability in the Marfan aortas. In conclusion, telmisartan attenuates aortic root widening through enhanced endothelial function and not blood pressure lowering, and it may prove to be superior to losartan in Marfan patients.
Thank you very much for this presentation. I think that fits really nicely with the recently published AIMS study that showed a pretty impressive outcome with a reduction in the aortic root dilatation as well as a 10 millimeter drop in blood pressure. So I think this from the proposed mechanism that there is additional NO activity that plays a role for this telmisartan, I think is quite interesting and exciting. I don't see any other questions on this nice abstract. So with this, thank you very much, Dr. Tehrani, for your excellent presentation.
Thank you for having me.
Thank you. And we can move on to the next presentation from Dr. Tierney.
Thank you for allowing us to present our work entitled Children and Adolescents with Marfan Syndrome, 10,000 Healthy Steps and Beyond. As you know, aortic dissection is the most life-threatening complication of Marfan syndrome, and due to this risk, clinical emphasis has been on what types of exercise to avoid rather than promoting regular exercise. These patients often also lead sedentary lives due to self-imposed limitations. There's recent work that has shown in mouse models that regular physical activity can improve aortic wall structure and function. Also, there's recent evidence in Marfan patients that stiffer aortas are associated with a faster rate of aortic root dilation and higher risk of aortic dissection. Based on this information, we hypothesize that regular exercise, defined as 10,000 steps a day, can improve aortic stiffness in children and adolescents with Marfan syndrome. These are our inclusion and exclusion criteria. We basically asked our participants to take at least 10,000 steps a day for 6 months. We also had a control group that was age matched with our participants. At baseline and at the end of the intervention, we obtained an echocardiogram to assess the aortic root dimensions and ascending aortic dimensions, as well as the stiffness. We assessed arterial stiffness also by arterial tonometry, and we tested endothelial function by EndoPAD. 24 Marfan patients were enrolled. They were at a median age of 14.4 years of age. 22 of these 24 completed the intervention, and they took an average of 7,709 steps a day. What we see at baseline is that the majority of these patients were leading sedentary lives, and their aortas were stiff. And we can see that in a lot of these patients, the parameters we were looking for were going in the right direction. However, what became statistically significant for us was the rate of change of the aortic root Z-score in controls versus patients in the intervention group. So what did we conclude? Our baseline data confirmed that pediatric Marfan patients have stiff aortas and they lead sedentary lives. Our results suggest that this lifestyle intervention is feasible, and regular low-intensity exercise might have potential to improve aortic root characteristics in children and adolescents with Marfan syndrome. Thank you for your time.
Thank you very much, Dr. Tierney, for this presentation. I think it's exciting, and we definitely, it's a topic close to my heart to get kids and people moving. My first question I have is, what was the baseline demographic levels, and what was the family baseline activity, and did it make a difference in your cohort?
That's a great question. We actually did not collect information on family fitness. We did collect their accelerometer data at baseline before they started the intervention and went by that. But that's an interesting one. We can even retrospectively collect that data by surveys now.
And when they increased their steps, did they increase it throughout the day, or did they have more short bursts of increased activity?
It was, so the way Garmin actually records the data is per day. I don't have a picture of it in here, but basically what you see is how many steps they took throughout the day. It doesn't say what time during the day, but that will also be interesting to see whether there are certain times they are more active. One thing we noticed is in the first month of the intervention, they were really eager. And then their interest, you could see, decline. They kept, they kept a certain step number, but they were not as good as their first month if you look at their 5th and 6th months. So it's definitely hard to keep them engaged at this level with just a Fitbit or with something like a Fitbit where we just ask them to take steps. I think truly, if we want to make them more active, we need to engage them in activities they enjoy, basketball or, something that they can do recreational level or dancing, rather than just walking, which I think is boring for them.
I think it's similar findings we had here at the University of Michigan with Dr. Charlene Day to make this intervention durable in patients with hypertrophic cardiomyopathy.
Yeah.
I would like to ask a question on behalf of Dr. Lindsay, who's asking if there was any difference in the aortic stiffness based on medications, beta blocker versus ARBs.
We had a very small cohort, so we haven't even looked at it. I doubt that we would see much of a difference. We didn't have a lot of patients on different medications. There are 12 on atenolol and or losartan, so there wasn't a big group that we could look into. But it's something we could add and see if there is a significance. It's a relatively small cohort for sub-analyses.
And Dr. Roman is asking if the intervention reduced blood pressure and thereby improve the vascular function?
The blood pressures at baseline were normal, and from pre to post, we did not see a change. So hard to tell, hard to answer that question.
What are your steps to, where do you want to see this, how this involves, and what kind of study would you kind of plan as a next level?
I think the next thing should be a randomized controlled trial with a little bit more engaging physical activity, probably something that involves more live video conferencing, some tele-exercise segment to it, maybe a running club for Marfan patients. That is a bit more fun, where they can also see each other, feel like they're part of a club, and they're all in the same club. They're all Marfan patients. They all have joint pain, and if they can jog together with a coach, I think that will actually be more sustainable. They can maintain it more, and we will probably see more benefits.
It's wonderful. Thank you so much. I don't know if I don't see any other questions, but maybe they come up later. Thank you, Dr. Tierney.
Okay, great.
Thank you. And now we move on to the last presentation from Dr. Sujen about smooth muscle cells and ACTA knockout mice.
Hi everyone, my name is Zhen Zhou, a postdoc from Dr. Diana Milowit's lab. It's my honor to be here and represent our team to share the update in one of our projects about the role of smooth muscle cell PDGFR-beta signaling in thoracic aortic disease. Active mutations have been identified as a causative factor of heritable thoracic aortic aneurysm dissection by decreasing smooth muscle cell fourth generation. Several of the point mutations in ACT2 gene could also cause occlusive vascular diseases such as early onset coronary artery disease and stroke. Our in vitro study shows that mutant smooth muscle cells have increased migration and proliferative capacity, and the left carotid artery ligation enhances neointimal formation due to increased smooth muscle cell proliferation in the ACT2 knockout mice. Our study also shows smooth muscle ARP actin deficiency induces overexpressed and activated PDGFR-beta. Further treatment with imatinib, the tyrosine kinase inhibitor, blocks the increased smooth muscle cell proliferation and the neointimal formation. Based on our previous data, we found ACT2 mutations result in loss of smooth muscle cell contractile function, driving non-elastic arterial dilation, and gain of smooth muscle cell proliferative function, causing small muscular arterial occlusion. However, what's the relationship between smooth muscle cell proliferation and thoracic aortic disease remains unknown. To explore the answer to this question, we used tamoxifen-induced smooth muscle cell-specific PDGFR-B lockout mouse model and crossed them into ACT2 knockout mice. We first confirmed the PDGFR-B knockout efficiency in the ascending aortas, and then measured the aortic diameters with ultrasound. The diameter of aortic root non-significantly decreased in the ACT2 wild-type mice, while it significantly enlarged in the ACT2 normal mice. However, there are no differences of the ascending aortic size among 4 groups. Interestingly, tail cuff blood pressure measurements showed similar results within both ACT2 wild-type groups and knockout groups. The smooth muscle cell-specific PDGFR-B knockout shows no effect on the blood pressure regulation. In sum, our current data provides evidence to show that inhibition of smooth muscle cell proliferation impairs the aortic integrity and predicts the thoracic aortic disease. Thanks for your attention, and I'm glad to answer your questions.
Thank you very much, Dr. Zhu, for your presentation. And if I can start, kind of like, I think that's a really concerning findings in the way that you have like a 2 or 3 hit model, that maybe some medications that inhibit the tyrosine receptors have really a profound impact on patients with ACTA2. What kind of medications that we know and use in clinical practice would affect this platelet-derived growth factor beta receptor that we know of?
There are several tyrosine kinase receptor inhibitors have been used to treat the tumor in clinic. So
if we use these drugs, such as imatinib, we have been used in our previous publication in 2013. In that paper, we used imatinib to treat the mice. We used the left carotid artery ligation to decrease the neointimal formation. So that drug has been used in clinic for several years. If imatinib or such other PDGFR beta signaling inhibitors used in patients with ACT2 mutations, I think those drugs may be a trigger for the thoracic aortic disease in these patients. We may be use them with cautions.
Yeah, I think your really excellent work shows that we really have to pay attention to the medical treatment, and there can be quite often a second hit, like an unintended hit on patients with underlying aortopathy, like an ACTA2 mutation. Do you think there are other kind of receptors that you think play a major role in increasing the susceptibility for aortic disease in ACTA2 deficiency?
Actually, in the ACT2 mutations, we have just found the increased PDGFR beta signaling are overexpressed. We haven't looked out for other tyrosine kinase receptors or some other membrane receptors. And in another mouse model, in the MYH11 R247C mouse model, we have done the RNA sequencing in the thoracic aortas. We found that increased FAK, focal adhesion kinase, they are activated. So maybe in different mutations, we have different activation or overexpressed signaling pathways in different mouse models. And in the mouse models, maybe there's still a gap between the mouse models and human patients, because we haven't got some of the data from the patient's tissues. So we are still working on that, make them consistent. So I think the next step, we are going to combine data from different mouse model and also the dissected patient tissues to make them consistent to find out whether there is a common signaling pathway that triggered thoracic aortic disease.
Thank you very much. I don't know if Dr. Braverman is still in the room here, and there came a question from Dr. Milovich, and I was wondering if Dr. Braverman is still available to answer these questions. It's about when women are no longer at risk for a peripartum dissection. Is it 3 weeks? Is it a month? How long do you think this risk extends?
I'm still here because I'm drinking water as opposed to the wine that others are drinking. So I'm still here with you.
Good, thank you. So yeah, go ahead, please.
So the question was about how long after postpartum a woman is still at risk for aortic dissection.
Yes.
You know, of the 29 women in the IRAD, one was 3 months postpartum. So I think there is still a risk. That was only one, but it was interesting that of the 45% or so that were postpartum, the average number of days was about 12 days. And I think the message is that it's not just the first or second day postpartum. So we should explain symptoms of aortic dissection to women who would have risk for that, so they can advocate for prompt attention. I think that's the thing to save a life in that situation.
Okay. Thank you very much. And then if Dr. Tierney maybe is still available, there were several questions about her exciting abstract, and they relate to what could be the potential mechanism, how exercises improves the stiffness of the aorta. You're on mute.
What was the question again? Sorry, I'm on.
If you can probably speculate a bit about the mechanism, how this exercise program improves the stiffness of the aorta.
So hard to tell in humans yet. We have collected blood, and we will be actually analyzing it in Arizona by my colleague Mitra. But what she has shown in mice is that regular exercise in mice or mouse models is that it actually decreases expression of MM2 and MM9 and the aortic wall of these mice. We're hoping that it's a similar mechanism, hard to tell, but that's that's how we actually came up with the project, and that's what it's based upon.
Thank you. So with this, I would really like to thank the presenters for an excellent presentation. I like to thank the audience for questions, and thank the organizer for this meeting. Hopefully next time we can share it in person and with cocktails in our hand. But I thought it was quite interesting, even with the virtual form. Thank you very much, and I return it back to Dr. Eagle.
Thank you.
I want to salute all of our young presenters, including Dr. Braverman, of course. We received almost 40 abstracts. They were all great. They're all winners as far as I can tell. And when we look at the future of aortic research, it's represented in these very, very talented young people who are pushing the boundaries that we need to push, frankly. So I salute all of our poster presenters and also those who submitted abstracts and their mentors, of course. And Marion and Joe Grima, who helped us identify the abstracts for presentation tonight. Now I want you to get ready for a Saturday morning breakfast with the GenTAC Alliance. We'll kick off at 9 o'clock. Go on the Whova app and look at those plenary sessions. There's more than 20 of them. They're about 10 minutes each. And they're superb on all aspects of genetic aortic disease, from surgery to medical therapy, genetics, translational biology. If you review them in advance, you'll be ready for the key points that are presented by each of the faculty, and then a very active and robust Q&A session that will follow. So I really look forward to seeing you all on Saturday morning. I want to thank you again for attending this first part of the GenTAC Alliance, and we'll see you Saturday. Bye-bye.
Bye.
Bye, Kim. Bye, all.
Bye-bye.
Marianne. Thank you.
Night.
Bye, guys.
Bye.
Thank you very
Thank you.
much.
Bye-bye.